biologics is the last sort of pit stop here. I'm sure you're all aware of these agents that exist. Remicade, which is used in ulcerative colitis, used in Crohn's disease, used in rheumatoid arthritis, psoriatic arthritis. You're always seeing something, you know, on the TV. Enbrel, another biologic for rheumatoid arthritis. And these are agents that are, and I've taken this again from a Crohn's and Colitis Foundation slide. These are genetically engineered, basically from living organisms and products such as proteins, antibodies, and genes. And these then in turn interfere with our body's inflammatory response in IBD by targeting specific proteins or enzymes that are playing a role in the disease. And the first group of these are called tumor necrosis factor alpha inhibitors. And what they do, there's the factor TNF alpha, which is thought to be one of the agents in this huge inflammatory cascade that is thought to have a significant impact on inflammation in the intestinal tract. And these agents then bind this TNF so that it is unable to bind and exert its inflammatory effect. The first of which was infliximab or Remicade, which is given intravenously. Humira or adalimumab is given as a subcutaneous shot every 2 weeks. Cimzia is another agent which is given every 4 weeks. There's another group called adhesion molecules, and these are on white cells, which are then sort of hone in on the intestinal lining and deliver various interleukins, other signals that result in inflammation. And these medicines are actually called adhesion molecules. They bind to these cells and prevent them from resulting in inflammatory response. And one of these you may have heard of is called Tysabri, which was in the news not too many years ago, because it was used to treat multiple sclerosis. And there were some patients who developed something called progressive multifocal leukoencephalopathy, which is a white matter disease that can affect the brain and can be fatal. So people have been a little hesitant about using Tysabri or natazumab with Crohn's disease. Originally it was taken off the market, now it's come back, and actually in Crohn's disease you can measure an antibody against the virus that's responsible for this white cell damage. It's called the Jacob-Creutzfeldt virus. And you can now measure an antibody against it, and if you don't have the antibody, the likelihood of developing this leukoencephalopathy goes from about 1 in 1,000 to 1 in 10,000. And those patients with Crohn's who have been treated with this medicine, to date, no one who has had a negative antibody have developed this disease, this PML. So it is being used. I think people are less fearful of using it, but it's another agent in those people who have failed using the typical tumor necrosis factors. As I said, basically inflammatory bowel disease, this tumor necrosis factor is found to have increased concentrations, and these antibodies against tumor necrosis factors, they downregulate the production of this inflammatory chemical or cytokine, which results in severe inflammation. So we don't really need to go, but it does this by various methods of doing it, and one of which is what's called direct apoptosis, is actually causing direct cell death of these inflammatory cells. Anyway, you treat people with these agents for if they really have trouble, if they have moderate to severe disease. And people of moderate to severe disease with a history of response to infliximab and then they subsequently lost it, you can use other agents if they've lost response to another. Again, steroid sparing is very important. You start people on TNF agents, and not always, but generally you can get them tapered off. It's used for fissures and fistulas. Primarily, Remicades been effective in that. And now people are looking at this in terms of treatment of early disease, like a top-down therapy. Someone comes in, has really severe disease, treat them with infliximab, maybe usually now with an immunomodulator, kind of really attack the disease from the top. Actually, in doing so, has resulted in various studies showing that, whoops, with that, there are associated reductions in the rate of hospitalization and in surgery. This just goes to show you, these are some of the risk factors for surgery. You look at, in 1 year, almost 30% of patients who are initially treated with steroids for Crohn's disease will end up at surgery. If you look at risk factors for people who have bad disease, this is 5-year course after a diagnosis. If you're young onset of disease in young patient. If the disease is primarily small bowel and colon versus small bowel is worse actually. Smoking status. Smoking increases risk. If you have disease involving the perineal area, and if you needed steroids with your first flare, all of those are pointing towards severe disease. And this just makes it a little simpler. Young age of onset, if you have these fistulizing diseases we talked about, sort of contracts between areas, early use of steroids. When you look in the colon, you see these really deep ulcers, not these kind of shallow type things. If you have high antibodies to certain, this is what I was referring to about the microbiome with the colon, various markers have been found against these various bacteria. And those who have high serologic markers also tend to have a high risk for surgery, and smoking certainly. And this is what I'm talking about. If you take, here are these, for 3 people, it's like, if you look at patients who have, they're looking at 3 basic antibodies to microbes in the gut. And if you don't have any of these, the likelihood of progression, although drops some, is less than 50%. If you have 1 or more of these antibodies, look at this, the probability of is time to progression is much sooner. When you're out here, you're doing fine. But those who have these antibodies, you can see the probability of progression fast. Again, this looks looking at oral steroids in the first 6 months, someone who smokes, small bowel disease. Those are the keys. In general, and I'm not going to go through every study in the world, in general, people who are treated with these biologics have a clinical response, and that's based upon various studies. Most of them use what's called a Crohn's disease activity index, which is about 8 to 10 different criteria, including number of bowel movements, blood, palpable mass, etc. Is about 60%, and actually remission is 35 to 40%. Again, steroid, you can get people, at least in the infliximab studies, if you put them on anti-TNF agents, people who are steroid dependent, you can get them off at least 27%. They're safe in pregnancy. We now have good blood tests to assess levels of the drug as well as antibodies to the drug in terms of monitoring patients. Here's a person who has active Crohn's. Look at these nice, deep, ugly ulcers. And they were treated with infliximab, and that's after treatment, which is pretty impressive, meaning the ulcers are all gone. I mean, it's not perfect. You still have some mild inflammation, but it is incredible in terms of, I'm just going to go through. There are some possible infusion reactions, though. Let's go faster. You can have some reactions that can occur with the infusion. A lot of those, if you slow the infusion down, you can then restart it. And I'm talking primarily about infliximab because infliximab has about a 5% what's called chimeric. It has about a 5% mouse DNA in it. So there's a more likelihood potential of antibodies against it. And you can have some reactions that can occur 2 to 14 days out. Again, safety class, one of the big things is you get reactivation of tuberculosis. Some people can develop what's called lupus-like reaction. Again, this PML. There is a slight increased risk in non-melanoma skin cancers. And again, lymphoma, though again is not huge. And now we're seeing this thing called hepatosplenic T-cell lymphoma, which before use of biologics and immunomodulators and IBD might be less than 19 cases in the world. There are now maybe double that number, and it appears to be in patients we see it in patients on both combination of biologics and immunomodulators. And at one point several years ago, all people who treated IBD stopped using both agents together. They used just the biologic agent because they were concerned that with the combination that the risk of this hepatosplenic T-cell lymphoma was too high. Well, subsequently, they found out that it likely, well, before we get that, is likely due to the immunomodulator, the azathioprine, and that this occurs primarily in males under the age of 35. So if you don't use immunomodulators in young adults, it's unlikely that they'll get it. But again, you've got to look at risk of disease versus progression versus side effects. Now, this was a great slide. Dr. Hanauer from Chicago, who's one of the top people in inflammatory bowel disease at the University of Chicago, tried to explain to someone, when someone says lymphoma to you, everyone sort of drops back and says, wow, I don't want to take that medicine. The risk is maybe 2, 4 in 10,000. This is the risk without medication. This is a phone book. This is, on this phone book, right there is the risk without medication. If you're taking just an immunomodulator, that's 4 out of 10,000 names. Whoops, I'm not going to go through all those. And then if you're taking both, that's the risk out of all these people. It looks like, when you look at it this way, it gives you more confidence in saying, okay, it's a risk, but maybe it's something I can accept, especially with my disease. So again, we talked about this hepatosplenic T-cell lymphoma. Biologic agents, we now are using levels of disease, levels of the drug and antibody to monitor treatment. Unfortunately, only Remicade has available antibodies and serum levels available. They're going to be coming out with the others, hopefully within a year or two. Again, you have to also, people ultimately may lose response to these agents, and you have to figure out why. Is it because they're developing antibodies? Is it because they have more active disease, which is consuming more drug? Again, if you have antibodies to any of these medications, you have to think about, well, maybe we need to change to a different medication. And here, for example, if you measure serum level and the medicine isn't present, then you need to go to another agent like natazumab, for example, here you've got antibodies to infliximab. Well, it's not going to be effective, so we need to go to a different TNF. Here you've got no antibodies, so either you increase the dose because you're not being effective, or you decrease the interval so you're getting a higher concentration. And here, again, if you have medicine is present but you have no antibodies, well, you got a drug that's there but there are no antibodies and it's not working, so you got to go to a different class. And that's when you look at someone with natazumab. Okay. This is real quick. Basically, this looks at people who are on both agents for a year. The likelihood out, you can see, is that at least 50% remain in remission in a period of a year. Let's just keep going. So here again, this is sort of the mentality of this step-up therapy. Patients attain remission with less toxic therapies. You may have more toxic therapies reserved for more severe patients. It minimizes risk of side effects. But the disadvantage is people who are really sick have to almost earn their way to getting a better medicine. And you actually may have decrease in the quality of life before you finally get to the therapy that may be effective. And higher risk of surgery, disease isn't modified. So the idea is now maybe the idea is we should use early aggressive therapy, earlier use of immunomodulators, and now goals are trying to modify the disease. Aim now is actually mucosal healing. A lot of people come in the old days and they've had bloody diarrhea and pain, and the doctor, all they want to hear is, I want to hear they're doing better. So patient says, I'm doing great, I feel well. Well, the problem is they may be, but that's clinical remission or symptomatic remission. The problem is you might look in that person's intestine and he may have active disease. So what we really need to do is, by someone coming in saying they're doing well, is that adequate? And the answer may be that's not adequate, because there are many people who will come in who say they're having terrible symptoms, and you do a colonoscopy and it's totally normal. So then what are their symptoms? Well, maybe they have irritable bowel, which is very common as a superimposed on people with inflammatory bowel. Someone will come in and say, wow, doc, I've had 6 flares in the past 3 months. That's 6 flares? And I said, well, how long do they last? Well, usually it's just like 1 day. And I'm thinking, well, you don't have a flare of Crohn's disease in 1 day. And they say you get cramps, they get diarrhea, it never wakes them up at nighttime, and basically it's an irritable bowel which is superimposed upon their underlying disease. So you have to look at all aspects of life. And I'm going to pretty much wrap it up here because, again, these biologic agents have very good response, remission. We've demonstrated actually with Remicade that you actually can get healing of the mucosa, which ultimately is what you want. In ulcerative colitis, that's easy to assess because the disease only involves the superficial layer. Some people will argue just because you see the lining normal in Crohn's disease, are you having true mucosal healing, because it involves the full thickness. So if you actually look in the layers deeper to the superficial layer, is there true healing there as well? Okay. I'm just going to say a few words about surgery. We talked already about saying the chance of someone needing surgery ranges anywhere from 2/3 to 3/4 of patients in their lifetime. These can involve, what we talked about, sometimes someone will come in and they have a stricture, they're causing obstruction, pain, and sometimes just simply removing that small stricture, which may have occurred over a period of 10 years. You resect it, put them back together, and they'll do great going on with maybe not much significant disease. So sometimes intervention of surgery may be very good. Again, we can talk about we're needing to resect various parts of the bowel. Again, the main thing is, I'm not going to go into detail, with Crohn's disease, surgery is not curative. One quick thing, which is now becoming more of an issue with inflammatory bowel disease, is nutrition. The thing is, there's no specific diet, as we talked about, that has an effect on your disease or will make your disease better. But it's important, though, if you have active disease, that you maintain an adequate diet. Because one, you're losing nutritional things. One, you first of all, you may have no desire to eat, you have pain. You have active disease, you're losing electrolytes, you're losing fluid, you're losing protein, you're losing decreased absorption of nutrients, especially in the small bowel. Proximally, you could be losing calcium, iron, distally, B12, and fat-soluble vitamins as well. So the importance of nutrition is maintaining a good diet, which helps in terms of quality of life and also potentially long-term outcomes. As I said, there's nothing you really know that diet alters inflammation. And actually, there are some foods, like everybody, that people can't tolerate. Many people, some certain foods may be a problem, so you develop food diary. You eliminate certain foods that you find day after day that may be causing exacerbation of symptoms. You want to maintain a well-balanced diet, hydration, electrolytes, nutritional intake. Real quick, this is just a quick thing on alternative therapies. I'm sure many people have talked about parasites in use in treatment. There have been some anecdotal studies of people who have consumed whipworm eggs, and suddenly their disease, which has been severe, is now in remission. There is going to be a national study for this, and the question is, why? What is the immunologic role that's causing this downregulation of inflammation? Is it something that the worm is providing? Is there some sort of symbiosis? We don't know. And again, the indication for the research project is to find out what is the immunologic basis of why it may be effective. Curcumin, which is an abstract of turmeric, also has been done in some small studies and have shown that it's prevented some relapses versus using mesalamine. There's some bigger studies that need to be made. Fish oil supplements, everyone keeps trying to find some other role for them. It may reduce pain and inflammation, but really there have been no studies and at least anything consistent in terms of any trials that have shown benefit. Again, people are always looking, particularly inflammatory bowel disease patients, looking for something that may be a benefit. This is from the Crohn's colitis presentation, and these talk about various products, probiotics, meditation, acupuncture, various different options in terms of treatments that may or may not be effective. And if you look at what are these alternative medicines do, about 41% are herbal medications. Again, this is from the CCFA presentation. About 28% have some special diet they take. Probiotics, basically we're trying to restore the good bacteria to balance the sort of microbiome. They may be beneficial in helping recovery, maintaining remission. VSL-3 is one that may have some effect in Crohn's disease and in people who have this pouchitis. Again, you got to talk to your family doc. This is a review of different probiotics, which actually have shown no evidence for efficacy and maintenance of remission. And these are various Saccharomyces boulardii. Again, bottom line, this is sort of, I'm going to leave it at this. Inflammatory bowel disease really involves a comprehensive management. The goals, one is obviously is to control symptoms, treat the inflammation, complications. You want to minimize toxicity. You want to aim for remission. You want to make sure nutritional deficiencies are repleted. You want to improve quality of life, prevent cancer. And this is just a quick thing about this step-up therapy, an early aggressive biologic versus management of Crohn's disease. Here's the step up, here's the step down. And this is just one thing looking at ulcers in Crohn's, treating with biologics, starting from the top, and here's going from your mesalamine upward. Complete ulcer disappearance, 73%, step up 30%. So the problem is you can't do step up in everybody, because it turns out probably 30 to 32% of patients don't need aggressive therapy. And the question is, who does? And that's what we're sort of looking at now. Who are the people that have the bad disease? Who are those who are going to end up with the strictures, the obstructions, the cancers, and figure out who are those we need to treat. Lastly, quality of care. This really has led, I think about 2 to 3 years ago, I had gone to the Crohn's and Colitis Foundation meeting in Florida, and there was a lecture by a physician named Corey Siegel, who's from Dartmouth Hitchcock. And he started talking about quality of care. And the thing is, this is a very complex disease. And this we didn't even talk about ulcerative colitis. Many facets you have to worry about. Drugs, monitoring, steroids, side effects, roles of screening for cancer. And you really need a quality of care program that's going to make sure that a patient with inflammatory bowel disease is getting the best care that's available. And that kind of led me to wanting to develop that program at Cooper, which about a year and a half, 2 years ago I started doing. Also because the fellows were seeing patients who were coming into the hospital, get treated with steroids, they get sent out, and they have no idea how to manage outpatients. So again, this quality of care has been looked at from the Institute of Medicine. Quality of care is a mechanism to ensure the best new research and ideas don't get left behind in journals, but get applied equally to all patients. And again, as Dr. Siegel had stated, it's identifying variation in the care, an initial step in quality improvement. It's like going to one hospital versus another. You may get one type of care, you might not get the same care. So the idea is to develop certain quality characteristics such that if that is the gold standard, that all people who ultimately want to treat inflammatory bowel disease will be treating at that level, or if not, they will then change their program or care to the point where it improves it and brings it up to, you know, the level of the others. Again, quality of care in terms of screening for colon cancer in ulcerative colitis and Crohn's, vaccination status in these people. For example, if you have someone on a biologic agent, you can't give them a vaccine for varicella, which is chickenpox. And if you're in a home where a young kid has chickenpox and you're on biologic agent, there have been reports of these people dying from disseminated disease. So if you're going to start someone on biologic, checking antibodies, various titers, administering vaccines before you start treating. You do pre-evaluation in terms of checking for hepatitis, tuberculosis. You screen for those people who are on steroids for osteoporosis. You follow labs for toxicity in these in the immunomodulators. You check yearly function of the kidneys on people who are on mesalamine. About 1 in 1,000 will develop an interstitial nephritis. You look at tobacco smoking, yearly dermatology exams for skin cancers. Hospitalized patients, they should all get prophylaxis for deep vein thrombosis. And Clostridium difficile infection is a 6-fold increase in ulcerative colitis patients compared to others hospitalized. So with that, I and Dr. Judge have developed basically patients' management using these quality of care criteria, using biologic agents, including Tysabri and this new antibody test where you have an infusion center for Remicade. We have a core group of consultants who, like infectious disease, rheumatology, psychiatry, so that if someone is having an issue, I can pick the phone up to that consultant and immediately be able to get that patient seen in a timely fashion. Availability of new medications. Again, these are some of the consultants we have, and that's it.